Good morning, everyone. We are going to talk today about uterine rupture. We'll study the definition, we'll study the causes, and the management of the following. So, let's define what do you mean by rupture of uterus. It means disruption of the continuity of all the uterine layers beyond 28 weeks of pregnancy. Now, let's come into the causes. Causes can be divided into during the pregnancy and at the time of labor. And further, it can be divided into spontaneous and iatrogenic causes, as you can see in the given flow chart below. Let's start first during the pregnancy. If during the pregnancy, let's study about the spontaneous causes. And the uterus is intact, there are no scars, then the causes will be like multipara, any congenital malformation of the uterus, abruptio placenta. These can be spontaneous causes in an intact uterus. And if it is a scarred uterus, then any previous cesarean section scar dehiscence or any hysterectomy scar, these can be the causes. Now let's come to the iatrogenic causes during the pregnancy. It can be due to the traumatic causes or by attempting external cephalic version or use of drugs like oxytocin and prostaglandins. Now coming to the causes during the labor. During the labor, it can also be divided into spontaneous and iatrogenic. In spontaneous, we have intact uterus and scarred uterus. Scarred uterus causes are same like the CS scar, myomectomy scar, or any previous rupture scars repair. In intact uterus, we have grand multipara, congenital malformed baby uterus, or any obstructive labor. In iatrogenic causes, we have vaginal operative deliveries, or when someone is trying internal podalic version, or someone is trying manual removal of placenta. These are the surgical and traumatic causes, and oxytocin and prostaglandin as usual. So coming to the management. In management, it's divided into two parts: prophylaxis and the actual management, definitive management. In prophylaxis, we can actually classify the high risk patients already before the delivery. We can use judicious use of uterotonic drugs. We could avoid instrumental deliveries or any kind of trauma. In definitive management, we can there are two components of definitive management: resuscitation and laparotomy. In resuscitation, we manage the airway, breathing, circulation. In laparotomy, we give a central midline scar followed by we can do a hysterectomy if the bleeding is not even stopping at all, or we can just repair the scar and sterilize it. So this was all about the management of ruptured uterus. Thank you for watching. And the female will present as with severe pain, maybe when contraction have stopped, there will be bleeding. She will be in shock. The fetus will be in distress. You can hear the bradycardia, and the differentials can be even abruptio and placenta previa. This is a clinical profile of the patient.